And finally, in our discussion of rheumatoid arthritis, we will discuss the clinical manifestations. RA is, after osteoarthritis, the second most common form of chronic arthritis, affecting approximately 1% of the adult population worldwide. Unlike OA, RA is a systemic inflammatory disease, and features such as fatigue, low-grade fever, and an elevated erythrocyte sedimentation rate help distinguish RA from OA. While articular manifestations can affect any of the synovial or diarthrodial or movable joints, the most common joints affected are the metacarpal phalangeal or MCP, proximal interphalangeal or PIP, and metatarsal phalangeal or MTP joints. Involvement of these joints is symmetric, affecting both sides of the body. Other joints affected include the wrists, knees, elbows, hips, and shoulders. Other joints affected include the wrists, knees, elbows, hips, and shoulders. Another point of distinction from OA is that RA spares the distal interphalangeal or DIP joints, while these are commonly involved in OA. Stiffness of joints in the morning or after a prolonged period of rest lasts for at least 1 hour before improvement ensues. While RA affects the cervical spine, involvement is typically restricted to the upper cervical vertebrae. Soft tissue swelling around the affected hand joints is common. In advanced RA, which is still all too common, swan neck deformities, which is hyperextension at the PIP joint, are observed. With involvement with synovial proliferation around the median nerve can cause carpal tunnel syndrome. Foot involvement occurs early, again involving the small joints of the toes. When large joints are involved, this can be prevented if disease-modifying drugs are started early. The entire joint surface is affected. Many patients require hip or knee replacement with dramatic improvement in their quality of life. Synovial cysts are fluctuant masses surrounding a joint. The best known of these, located around the knee, the so-called Baker cyst, is formed from excess fluid produced during the inflammatory process. Now let's talk about extraarticular manifestations. RA is a systemic autoimmune inflammatory disease. At some time during the course of RA, all patients experience fatigue, weight loss, and several cytokines cause proteolysis, and low-grade fever, which is low-grade fever is less than 38 degrees centigrade. These symptoms tend to be more common in patients who are RF positive, which accounts for 60 to 80% of patients with RA. Rheumatoid nodules occur in approximately 25% of patients with RA. Rheumatoid nodules are located subcutaneously on the extensor surfaces, especially the forearms. Rheumatoid nodules are believed to be caused by small vessel vasculitis. Rarely, nodules may be found in the lungs or heart. It is particularly noteworthy that patients with RA are prone to coronary artery disease. Contributing factors may be elevated C-reactive protein as a marker of chronic inflammation and sedentary lifestyle because of limitation of movement. Dry eyes from secondary Sjogren's syndrome are also not uncommon. Felty syndrome, which is the triad of RA, splenomegaly, and neutropenia, occurs in patients with rheumatoid factor and anticyclic citrullonated peptide or anti-CCP. Other findings may include hepatomegaly, thrombocytopenia, and lymphoadenopathy. Now let's go on to the laboratory findings. RF is an IgM antibody that recognizes the Fc region of IgG. RF occurs in approximately 50% of patients at the time of presentation, and another 20 to 30% become positive later in the course of the disease. In addition, the autoantibody most specific for RA are directed against citrullinated proteins referred to as anti-CCP antibodies. These antibodies are present in up to 70% of patients with RA and are greater than 90% specific for RA, correlating strongly with more severe erosive disease. Now let's discuss the diagnosis. Criteria developed by the American College of Rheumatology are widely used to diagnose RA. There are 4 clinical criteria that must be present for at least 6 weeks. Morning stiffness, arthritis involving 3 joint areas, arthritis of the hands, and symmetric arthritis. In addition, rheumatoid nodules, a positive RF, and radiographic changes demonstrating cartilage destruction and bone erosion are usually needed to establish the diagnosis. As noted above, a positive test for an anti-CCP antibodies is highly correlated with RA. Rheumatologists urge that patients with RA should be diagnosed and started on disease-modifying anti-rheumatic drugs, or DMARDs, within the first 3 months of the disease process. Because viral arthritis usually lasts no longer than 2 to 3 weeks, the rule of 6 weeks before considering RA still gives the physician ample time to confirm the diagnosis of RA. Now let's discuss the treatment. While RA is a chronic disease for which there is no cure, the advent of DMARDs and biologic agents have resulted in long-term remission in 20 to 40% of patients. As suggested earlier, prompt diagnosis followed by institution of treatment is expected to provide the best outcome. There are 2 general classes of drugs used to treat RA. The first class is the relatively rapid-acting NSAIDs and glucocorticoids, which provide relief of pain and decrease inflammation, but do not stop the progression of the disease. The second class includes a variety of agents termed DMARDs and biologic agents that do retard the progression of the disease. The onset of action of the DMARDs is delayed for 2 to 4 months. NSAIDs are useful to alleviate pain and inflammation, while tiding patients over until the DMARDs take effect, which requires 2 to 6 months. Non-selective NSAIDs act by inhibiting both isoforms of cyclooxygenase, which is COX-1 and COX-2, thus reducing inflammation of inflammatory prostaglandins. Again, non-selective NSAIDs do not affect the progress of the disease and therefore should never be used alone to treat RA. Glucocorticoids, first used to treat RA, have a fairly rapid onset and dramatic effect in reducing inflammation, pain, and stiffness, and slowing the pace of joint damage. However, as glucocorticoids have a myriad of untoward side effects, including osteoporosis, glucocorticoids should not be used for long-term treatment of RA and are best used as a bridge while DMARDs take effect. DMARDs have become the most prescribed drugs for the treatment of RA because DMARDs slow progression of the disease while ameliorating pain and swelling. Unfortunately, there is a delay in the onset of the full effect of DMARDs of 2 to 6 months. Methotrexate, or MTX, is the most widely used DMARD because it is taken orally once a week, has a low cost, and has a set of well-defined side effects. The mode of action of MTX in RA appears to be its ability to cause release of intracellular adenosine, which has anti-inflammatory and immunomodulatory properties. Thus, MTX used for RA relies on actions that differ from those exploited in cancer therapy, in which MTX antagonizes the action of folate in purine synthesis. The side effects of MTX include oral ulcers, nausea, liver toxicity, bone marrow suppression, and a hypersensitivity pneumonitis. Concomitant administration of folate can limit the development of the non-hypersensitivity toxic reactions. Another drug that has achieved some popularity is leflunomide, a pyrimidine antagonist that inhibits dihydrotonate dehydrogenase, dihydroorotamate dehydrogenase, thus impeding development of activated T cells. Hydroxychloroquine, an antimalarial, is often used in combination with other DMARDs. Rarely, hydroxychloroquine is associated with retinal toxicity. A large body of data implicating TNF-alpha interleukin-1 in the progression of RA has created the most exciting strategy for the treatment of RA, namely the biologic agents. These agents are large protein molecules such as monoclonal antibodies or soluble receptor constructs. This arsenal now includes agents directed against TNF-alpha, and one of these is etanercept, and also infliximab and adalimumab, and interleukin-1, which is anicara. So for TNF-alpha, it's etanercept, infliximab, and adalimumab, and for interleukin-1, it's anicara, a biologic agent that blocks T cell co-stimulation called abatacept is one that targets target B cells. Excuse me. A biologic agent that blocks T cell co-stimulation. This is called abatacept, and there is one that targets B cells. That's rituximab. These are all available. The TNF-alpha inhibitors take advantage of monoclonal antibody technology, thus creating recombinant fusion proteins. These agents are usually administered along with MTX. The TNF-alpha inhibitors have a rapid onset of action, improved clinical symptomatology, and delay progression of diseases as assessed by radiography. The most important side effects are reactivation of latent TB and vulnerability to opportunistic infections. These agents are quite expensive, and many insurers will not underwrite their use until a patient has failed MTX. Interleukin-1 receptor antagonists ameliorate synovial inflammation, but they are not as effective as the TNF-alpha inhibitors. Use of both classes in the same patient is contraindicated because of an increase in adverse reactions. The B-cell antagonist, which is rituximab, is directed against the CD20 antigen found on the surface of B cells. The drug depletes B cells by augmenting cell death. These agents should only be prescribed by a rheumatologist because they are fraught with potential side effects, and only a physician with considerable experience in their use can advise the best protocol for a particular patient. Visits to the rheumatologist every 3 to 4 months should be supplemented with visits to the primary care physician. It is important that the primary care physician develop good communication with the rheumatologist. And lastly, let's talk about comments on the case presentation. In our patient in the case in the first video, we talked about the clinical picture of symmetric swelling and tenderness of the NCP, MCP, and wrist joints lasting longer than 6 weeks, suggesting RA. RF, or rheumatoid factor, and IgM directed against the FC portion of the IgG is positive in approximately 2/3 of cases and is present early in the disease. A history of fatigue and lethargy is a common prodrome of RA, but it is neither sufficient nor specific to make the diagnosis of RA. The patient has greater than 4 of the required signs or symptoms of RA, including morning stiffness, swelling of the wrists or MCP, simultaneous swelling of joints on both sides of the body, and subcutaneous nodules and a positive RF. And lastly, subcutaneous nodules are a poor prognostic sign, and DMARDs should be promptly instituted. MTX, or methotrexate, has emerged as the agent of choice because of its fairly rapid onset of action, long clinical experience greater than 50 years, and a modest cost. Thank you very much.